So welcome again. So we're about to start our second session of the annual IANPHI meeting. This session has the title, Using Appropriate Methodologies and Metrics to Assess Vulnerability and Health System Resilience and Support Equitable Public Health Policies. So this session will explore methodologies and metrics, as the title says, for influencing public health policies, focusing on health system resilience and climate change adaptation. It will cover efforts to integrate monitoring tools for assessing health systems resilience with an emphasis on indicators for universal health coverage and health security. Additionally, this session will highlight countries' experiences in using climate, epidemiological, and socioeconomic data to assess health sector vulnerability to climate change, revealing disparities and the need for better adaptation strategies. So we'll have two main presentations, 15 minutes each. So our first presentation will be done by Dr. Sohail Saikat. He's a senior advisor at WHO Geneva. Professor Sohail, please take your stage. You have 15 minutes.
Dịch rồi lại dịch lại cho các bác. Để con này cho lại MC. Xem đầu đề của nó là gì?
Good afternoon, colleagues, and thank you, Chair. So, colleagues, if you reflect, I think we are just out of the lunch break. If you reflect this morning, I think there's a talk about polycrisis, that multiple crises like climate change and CD, infectious disease. I think it was very, very profound. And then we also having the global contractions, I think, in terms of ODA. But then if you reflect on our time during COVID-19, so the statistics is quite important there, 7 million death that you can relate directly with COVID-19, and then 14 to 17 million excess mortality. And if you look at some of these further breakdown of the figure, so the people who had comorbidity, who are socioeconomically deprived, and who are elderly, unfortunately, they died more. So it's not that a ballpark statistic. There are something very, very alarming. And the other important message that we all need to remember that, yes, the political and economic impetus on public health was very, very profound during that time. And there are many estimations of the impact, overall economic and societal impact. But we as organizations, we are very good in doing those number crunching when there is a crisis. But public health is a routine issue. We do not do number crunching or failing of public health in a routine context. So the word resilience, I think in their title, again, thanks and congrats to Duncan and his team. I think it's the 2 years that we are putting the word resilience in the concept of framing of the program. So on the right-hand side, you could see WHO's framework of health systems building blocks. So resilience is what we want us to achieve so that we can do better, we can perform better, we can more do a smart business. But public health is a mechanism for us to achieve that resilience. And resilience is not just for emergency preparedness and response. Resilience is not just for universal health coverage. It is to build baseline capacities so that same health systems can be more self-reliant. So the example of COVID-19 is not a good example where we had to bring all government machineries. So moving forward, I think by investing in resilience with public health, I think we can demonstrate that as a health community, we are self-reliant, which is very, very important. So colleagues, this is again, many of you contributed. We are all public health communities, but unfortunately, the fact is that as of until we came up with this list with IANPHI, nobody defined authoritatively what an operational public health should look like. What are those critical components of public health? What are their scope and boundaries? So this is a global list, at least providing that operational clarity that what public health should entail. Is it just only about promotion? Is it just all about protection? Is it all about public health emergency management? So we as an organization, WHO with IANPHI, tried to come up with this list as a unifying list for public health. And so this is a mega list, but there are further unpacking and repacking for each of these service delivery function as well as enabling functions so that countries can do their benchmark. All NPHI can do their benchmarking. Okay, this is where we are doing well. These are some of the areas of critical gap based on population health need assessment that we should all aim to do on a regular basis. So colleagues, this is a story of fragmentation. I think the word integration came up repeatedly in every meetings. But unfortunately, the investment in health sector, I'm sorry to say that is very, very transactional. I think we take the money from the taxpayer to build hospital so that more hospital bed is a way we can report back. Similarly, vertical disease program is how many people are treated for cholera, how many people are treated for malaria. Similarly, if you look at the humanitarian context, is also transactional. There is no bridging between response to recovery to longer term development aspect. So within that type of context, policy, plan, monitoring is very, very fragmented. I can give you many examples. So the overall health sector monitoring under universal health coverage or health security or on humanitarian context is fragmented, siloed, and parallel because we all need to report back to our taxpayer. So there is a major issue for integrated monitoring due to the way budgeting and investment has been structured. So colleagues, we as a WHO, we also have issue within the organization, but we as a team tried to look at these issues in a more objectively. So for the first time, we came up with a compendium of indicators that any countries can cross-check, can benchmark to measure resilience in their health system. So some of the fundamental principles that we applied, one is an all hazards approach, sector-wide development, both horizontal and vertical, and we position the indicators according to health systems building blocks with a public health lens as well as intersectorality. And this is one of the most downloaded WHO technical product since it was released in public domain. So these are some of the examples of the indicators. So it's not just an attribute. I think you could see some short name, but each of this indicator has got a metadata. We call it a technical specification. So any country can just directly take and apply them in their context. And if you look at some of those indicators, you could see that why I'm saying we are talking about sector-wide capacity development underpinning public health. And this is in public domain. The second one, I think thanks to the government of Canada and Public Health Agency Canada for collaboration with us. So we as a WHO tried to look at current health sector related monitoring at country level, global level, as well as those that are ad hoc about their consideration of public health. So for example, in Africa context, you all applying DHIS2, IDSR, and then you all participated in joint external evaluation. You all every year report to World Health Assembly for a state party annual reporting. And then those that are on universal health coverage sector, you all know about service availability and readiness assessment, which we now call harmonized health facility assessment. And then if you think about humanitarian context, there is a PDNA as well as there's a SPR handbook. So what we had done, we looked at all of these tools from a public health lens. And what we identified from these studies that some of them are really good in terms of looking at certain aspects of public health, like those are on the security sector, like joint external evaluation as part, they are doing very well to looking at certain aspects of public health. But the aspects of public health as an intersectoral accountability, public health has also domains of promotion, prevention, and then the interdependence between them. Unfortunately, none of those tools adequately cover. So the option there, unless we look at all of this assessment data in a more holistic way, more integrated way, we are going to come up with a planning instrument based on those data as another siloed one. So there is no tool, unfortunately, globally available, unfortunately, that focus on all necessary aspects of public health. There is no tool, no process in place that are applied at countries to look at overall public health capacity at country level. Unfortunately, this is the reality based on evidence that we collated. And thanks to Dr. Tam and her team for this collaboration with WHO. So very briefly, is not undoable, colleagues. I think based on the work we are doing, I think there is a source of data to adapt to the current context. So to look at what we are measuring at country level, how can we select and define that gap from a public health point of view, how can we build that capacity, and how we can institutionalize that capacity. I think that is the role we can expect from Ministry of Health and National Public Health Institute, and also link the assessment with a proper planning process. If we do not link it with proper planning process, the assessment will remain just an assessment. And there are already some planning tools available even in Africa context. You are all doing health sector strategic development plan and other plans. So it's good that we really transfer the public health underpinning in your national planning process so that it can go to the parliament, it can be budgeted, it can be actioned. So this is based on the work we are doing with Public Health Agency Canada. We also tried to come up with some dedicated indicators that countries can look at and apply in their routine health information system. Some of the indicators are focusing on integrated delivery of public health function and services. Some of these indicators are to look at overall systems capacity. Otherwise, if there is no systems capacity, you cannot expect that services for public health can be available, for example, at primary care level. So all of this will come up with a technical specification that countries can apply and contextualize. So colleagues, this is my final slide. So we as a WHO are going to embark on our new general program of work number 14 from 26 onwards. And so that is the way how we are going to interact with all of our member states. So for the first time in the WHO's history, we have a dedicated indicators. I think I can read as it is, as strengthening institutional capacity for essential public health functions and health systems resilience for the first time. So this could give us a legitimacy to work together and report back to WHO and all member states about what you are doing from your institutional level. So there are 3 sub-indicators. One, given that public health is dispersed, nobody can deny it. I think it came out very, very strongly this morning. I think Tracy from Wales, she mentioned about intersectorality like obesity, social care, and then I think some colleagues talked about the urban planning. So these are all integral part of public health. So one of the sub-indicators that we are asking with member state, do you have a multi-sectoral coordination mechanisms? We are not going to talk about whether a country has a NPHI or not. We are not going to talk about whether the NPHI is an autonomous or semi-autonomous or is absorbed within the Ministry of Health. But what we all need to achieve, regardless of the current status, is there a proper coordinating mechanisms that is functional, that is working, that is serving the population of that country. So that is number one. Second one, I think as I mentioned about the transactional nature of the way health system has been organized. So we wanted to check whether country's basic package of health services, whether it includes public health function and services there. If it is not included there, we cannot expect that services is going to be there. And we are even looking at the role of the primary care on public health functions and services. Then third one, we have a roadmap. I think, as I mentioned, given that the public health workforce is not just located within Ministry of Health, public health like veterinary sector, like the people who are working on flood protection, who are working on climate change, who are working on water and sanitation, they are also part of our public health workforce. We often bring them together during crisis, but that is an expensive model to bring them together. So we are trying to change it to identifying and mapping the public health accountability, public health competency that should be there in the allied sector, so we can count them and build their collective capacity so that we'll have a better denominator to define the health workforce for public health. So thanks a lot, colleagues, and thanks to Chair and my fellow speakers. Thank you.
Dr. Sohail, thank you for your great presentation. This was actually a great way to start this session. We cannot talk about methodologies and metrics without talking about the tools that are available. And Dr. Sohail brought us a great news regarding the WHO's global health strategies that will definitely support us on improving our methodologies and metrics to assess vulnerability, health, and health resilience. So our second presentation will be from Dr. Tatiana Marrufo. She is the program lead of the Environmental Health Program at the National Public Health Institute in Mozambique. Dr. Tatiana, you have 15 minutes for your presentation.
Good afternoon, everyone. So I'm going to present on behalf of the team from the environmental health, including the occupational health program at INS Mozambique. And we are bringing here our experiences of our country in addressing appropriate metrics to assess the vulnerability and adaptation of the health sector to the climate change. So this is basically the outline of my presentation. Let me move to the introduction. So this is Mozambique, is where we all are here today. And is a country that is vulnerable to extreme weather events. As per the global health risk, we are the 5th country that is most impacted by the extreme weather events, and mostly it's because of our location, as you can see in the Indian Ocean, close to Madagascar. And unfortunately, the climate projections shows that we will be facing in the following years an increase on the temperatures, delays on the start of the rainy season, and more frequency and intensity of the extreme weather events, which definitely will place an additional pressure to our sector, so the health sector. Fortunately, the Minister of Health, through the Instituto Nacional de Saúde of Mozambique, have been working in the past 8 to 9 years in addressing issues related to the climate and health. So to give a little bit of context, I want to say that recently our National Institute of Meteorology, not sure if you can see the first chart, has published the annual state of the climate in the country, showing that in the past 74 years, we have been facing an increasing in the trends of our annual temperature of our country, in which we have an anomaly of, in terms of increase of 1.2 degrees Celsius above the climatological normal from 1981 to 2010. And for sure, as we know, 2024 was the hottest year that we had. And you can see the peak in the last year, it's 2024. Unfortunately, historically, we have been faced by a lot of extreme weather events, namely droughts, floods, and tropical cyclones in Mozambique. And the trends are also increasing. So in the green, you can see the past decade, and we have been facing by a lot of cyclones. These are cyclones in the past decade. And these are showing from 1980 to 2024, the cyclones that we have been facing in Mozambique in the last years. So unfortunately, these trends are implies growing pressure in our health sector, in our health system in Mozambique. That's why in 2019, our country conducted the first vulnerability and adaptation assessment of the health sector to the climate change. And this was using a methodology from the IPCC, in which we addressed components of exposure, adaptive capacity, and sensitivity of the health system. And we had the opportunity to have at the end the health vulnerability index for each one of the 161 districts of our country. As the main results from this assessment, we do have that around 42 districts of our country show high to a very high HVI, which is health vulnerability index, accounting for 31.8% of our national territory and 24% of our population. We have, as a main result, also that at least 8 of our districts have a very high HVI, and 15 of the 20 are districts that are located in the urban area. So I wanted to mention each one of the components of this HVI, starting from the exposure. So the exposure we addressed using the climatic variables, so the extreme weather events, but also the changes in rainfall, in temperature, and also in relative humidity. And in these two different pictures, in the hub, the one it's showing actually the trends from 1970 to 2019. The variation of the first one is temperature. In the middle, we have rainfall, and the last one in green are the relative humidity. And here in the the picture, we are showing the trends in terms of the extreme weather events, in which we have for the 40 years, so 1979 to 2019, accounting for 12 episodes of droughts, 20 events of floods, and 21 from cyclones. But we are talking about 2019. From 2019 up to now, we have been facing a lot of more cyclones in the country. So this is what we have addressed in terms of exposure. In terms of sensitivity, we were mainly looking at how susceptible the health system is to the climate-induced disruptions. So we use different variables. For example, variables related to socioeconomic and demographic factors. We have used also the disease burden and epidemiology, taking into account the main climate-sensitive diseases such as cholera, for example, but we have taken into account also malaria, other diarrheal diseases, and also taking into account the country's epidemiology in terms of how we are affected by HIV, tuberculosis in Mozambique. In terms of socioeconomic and demographic factors, we took into account the population density, in terms of the vulnerable groups, so the number of children under 5 in the districts, also the pregnant women and elderly, so the vulnerable populations, and also we took into account the health system infrastructure so that we can address the different factors that make the health system susceptible to climate-induced disruptions. So the next one is the adaptive capacity, actually main concern to how the health system can minimize the risks, reduce also the damage, and enhance the resilience. And we have looked into different variables related to financial resources, health services, health workforce, water and sanitation, and some variables related to the social determinants of health. And you can see here in this table a lot of variables that we have used from different sources that we use the data that were available not only on the health sector but in the different other sources, namely the census data, data from different reports, from different surveys, and also data from the community, for example, the National Household Budget Survey report. We combine so different data coming from different data sources so that we can have our indicators to assess the adaptive capacity. So our main achievement with this assessment was that we had opportunity to have this district level climate change vulnerability index, in which we have not only information from the health sector, but also index from specific hazards, namely floods, droughts, and cyclones, and also the social determinants of health. Creating the evidence base to inform the national and sectoral plans and also the strategies in our country. Of course, we had a lot of limitations to conduct this assessment. The first one was definitely related to data. So accessing data, sharing data, and also the quality of data was one of our main limitations. For example, at that time when we were conducting this assessment, it was in 2019, and we didn't have the census, the 2017 census data available. So we have to work with the projections for 2017. And this is one example, but we had a lot of other limitations in terms of data coming from the different sectors, including the health sector. In terms of the meteorological data, so in Mozambique, we have a low coverage of weather stations, so the ground stations for meteorology. And this was a great limitation for us because we have a lot of gaps in terms of the historical data that we intended to use for the analysis. And in terms of analysis, we had to use proxy indicators, and sometimes with a lot of issues and question in terms of over or under representation of the data that we were using for analysis. And since we had low coverage of meteorological weather stations, we have to use reanalysis data coming from different sources in terms of satellite, the ones that we use for exposure. And these also raise some limitation in terms of underestimation of some of our indexes. In terms of way forward or perspectives, we wanted to also try to assess the vulnerabilities of our health facilities and also including the communities, because we think that these could definitely anticipate the risk and also enhance the health facilities to respond, to cope, and to recover from the climate related shocks or stress, and even to provide better care to the target population and including the vulnerable populations. So we wanted also to contribute with this type of assessments to provide a little bit of literacy, awareness, and also education to our health professionals, giving trainings for the doctors and health practitioners at the local level so that they can be aware of the inequalities and the risk of exposure that could definitely account for when they're taking decisions at the local level. And finally, we wanted to support the health sector on implementation of national adaptation plans and mitigation, namely the non-determinate contribution and also the HNAP. We are doing that actually. We are providing support to the Minister of Health to both plans. And as a conclusion, I just wanted to mention that aligned with the first presentation, we as INS Mozambique, we are contributing to resilient health systems to climate change, since we are providing information to monitoring and evaluation, the capacity of our health sector. But of course, we recognize that we have a lot of issues in terms of having appropriate metrics to deliver the data timely for the decision-making process. And of course, we are working in reinforcing the multi-sectoral collaboration through these plans that we are working and supporting the health national system in terms of climate change. And we are providing the information to inform these plans and also to incorporate appropriate metrics in the process of planning. So this is our contribution in terms of our experience in terms of vulnerability and adaptation assessment and using appropriate metrics in Mozambique. And thank you for your attention.
Thank you, Dr. Tatiana, for your presentation. Dr. Tatiana gave us some details on the experience of Mozambique in addressing appropriate metrics to assess the vulnerability and adaptation for the health sector to climate. As she mentioned, although we have this beautiful country, we are very vulnerable to climate change. So next, we'll have the second part of this session. We'll have 4 panelists. 3 of them are online, and they will be sharing briefly the country experience on how they're using different methodologies and metrics to support and influence public health policies. So our first speaker will be Dr. Carlos Hernandez Avila. Dr. Carlos, he's the head of the Governance and Knowledge Management Unit at the Instituto Nacional de Saúde Pública in El Salvador. Dr. Carlos, can you hear us?
Yeah, very clearly.
Perfect. Dr. Carlos, you have 5 minutes for your intervention. Please proceed.
Thank you. Good afternoon, everyone, dear attendees of this IANPHI Assembly. The National Institute of Health of El Salvador is very pleased to share the experience of the state of the Social Technology Foundation project using rapid participatory diagnosis and participatory mapping. El Salvador, as a member of IANPHI, attended to the workshop in Petropolis in August 2023. In this activity, proposal 4 projects to be developed were presented. One of them culminated in a multi-center study of social inequalities and inequities in health through the application of social technology. This study was developed together with Mexico, Argentina, Colombia, Paraguay, and El Salvador, advised by the Itaboray Forum of Fiocruz. Next slide, please. Next slide, please. It's necessary that you know that in El Salvador, there is a figure among the community health personnel called health promoters. El Salvador has 3,000 health promoters that cover the entire country and are distributed in 5 regions. Each promoter is the contact of the Ministry of Health with the community. Some of them come from the communities. In June 2024, the training of 2 INS researchers was carried out in Petropolis. During the process, methodological support was received from the Itaboray Forum team. In July, the materials were adapted and the project was presented to decision makers in El Salvador to subsequently coordinate with local actors in the communities. In August, the first training cohort of 70 health promoters began. This was difficult because we were going through a dengue epidemic in Americas. Even so, it was possible to complete the training. At the end of August, the country had a visit from Fiocruz team and the experience was systematized. This year, after coordination with the local authorities of the Ministry of Health, a training was carried out for 66 health promoters that ends this day in order to complete one of 70 health subregions of the country. Could you play the video? Health promoters has been training in the use of free access digital tools that allow them to immediately have their maps and their work areas, like the one you you have in the video. The area that we designed to work is near to our capital city, just 13 kilometers from the INS. There is a mountain terrain, limited transportation, and vulnerability of the terrain prone to landslide flows and few sources of economic production that result in inequalities and inequities in health. Social technology have become tools for working with the community, and their registration go from the analog to digital. This has presented an advance in the way of doing their work. A key element has been involved of the community leaders who work together with their health promoters in documenting their vulnerabilities and potentialities in favor of improving their health. In this process of intervening in the determinant in health, this experience is the beginning to make visible the needs of improve their condition from the community accompanied by the National Institute of Health. Thanks.
Dr. Carlos, thank you. Unfortunately, we had some technical problems and we were not able to see your slides, but I think they can be shared with the participants after the meeting. But thank you, Dr. Carlos brought us a different approach where El Salvador is using a participatory approach in collaboration with multiple countries from South America. Thank you, Dr. Carlos, and we will get back to you for questions from the audience. Please stay with us until the end of the session. So next, our next speaker will be from the Netherlands, Dr. Henk Ederink. He's from the Netherlands, and he is a top expert on public health foresight. So please, Dr. Henk, I hope you can hear us. You have 5 minutes to share your experience on the topic.
Okay, thank you and good afternoon. I hope you can hear me clearly. Shall I share the presentation myself? If that's fine. I hope you can see the presentation. Thank you for inviting me. I'm Henk Hilderink. I work at the National Institute for Public Health and the Environment in the Netherlands, and I'm there the top expert on public health foresight. And just to say a little bit more, what is then strategic foresight? That is a proactive and systematic approach to look at, let's say, different futures. And the plural is rather important there, that we are looking at all kind of different futures. And of course, those futures bring challenges, but also opportunities. And the foresight helps to identify those challenges and opportunities. It is also good to say, if you apply a foresight approach, it is also about uncertainty, all kind of uncertainty that we are facing in the future. We just have to look at the news today to see another source of uncertainty for the future. However, we can have a way of looking at that uncertainty in a more structured and systematic way. And it's not only the geopolitical uncertainty, we have all kind of aspects that play a role, societal uncertainties, technological, environmental, of course, with climate change, and economic changes as well. And of course, we want to be prepared for that and also build up resilience. And to do that, to do foresight, you have different methods like horizon scanning, scenario building, but also rather important that we are investing a lot in the Netherlands is the stakeholder participation processes. We don't have all the knowledge within our institute, and we want to include different perspectives on public health as well. And on the other side, we also have different kind of modeling approaches that we can also employ to do foresight studies. It is important, especially given that uncertainty, we don't predict the future. So we want to explore possible futures, for example, also to look at more desirable futures or undesirable futures that we want to avoid. And if you look at public health foresight, it's still lagging. If you compare that to climate change or the economic research domain, then you can see that they are already doing that for decades and decades. However, in public health foresight is still, let's say, in the first steps of becoming more mature. And fortunately, RIVM, the National Institute for Public Health and the Environment in the Netherlands, my institute, is doing strategic foresight already for more than 30 years. We have the Dutch Public Health Foresight Study that we do since 1993, the first one. We just published last year the 9th edition. And it's good to say we have a legal basis for that within the Netherlands. And that is independent of any political color of the administration. We are looking at the future. We are reporting about what are the important challenges for the future. We look at the future a long time from now, for 25 years. However, we do know that the changes are going very slowly. So we also try to translate that. What does it mean for current day policymaking? Because to end up somewhere in 25 years, you might have to start changing things now. And especially looking at climate change, aging of the population, we know those changes are very slow. We do that actually to put as an input for the policy processes. The commissioning client is the Ministry of Health, but also local policy makers are very relevant for the foresight study that we do. And what I said, we do have an intensive stakeholder participation process. And then we're not looking only at research, we're looking at policymakers, we're looking at the private sector, but also of all kinds of interest groups like the elderly, the young, patient groups. We involve them all in the process of doing a foresight study. And we're doing that actually, those foresight studies, we're looking at the future, what futures are we facing, and what are then the most important challenges. And those challenges are not only for policy makers, but also for society in general. And of course, we want to do something about those challenges. So for us, a foresight study is never complete without also translating that. What are then the options for action to do something about it? So taking into account the uncertainty that we're facing in the future, that is why we want to go to, let's say, the foresight informed policy making, taking into account the best evidence we have, but also accounting for the uncertainties of the future that encompass the future. Thank you very much.
Dr. Hank, thank you for your presentation and for sticking with the time. So we heard an experience from one European country, and Dr. Hank emphasized the uncertainties regarding foresight, but also the importance of stakeholder participation. And now we are coming back to Africa. We'll hear now a short presentation on the experience of Ethiopia. And we have online Dr. Mesai Hailu Dangiso. He is the Director General for the Ethiopia Public Health Institute. Dr. Mesai, it's a great pleasure having you in the meeting. Please share your experience.
Thank you very much. Good afternoon, everyone. I would like to share our experience, Ethiopian Public Health Institute's experience in terms of leading the nation's public health emergency management, public health research, laboratories, and national data management and analytics, as it is one of the oldest public health institutes in Ethiopia as well as in Africa. It has been providing public health services for Ethiopian population since 1922 with different mandates and names and roles and responsibilities. I would like to share you some of the national success stories and the mandates, and in particular in responding to public health emergency management and in public health research and data management and analytics. This is a legal framework of the Ethiopian Public Health Institute and its establishment. With various mandates. There are 5 basic mandates of the institutes, the public health research, to provide evidence for health, Minister of Health. Even we use evidence generated from public health research for our programmatic responses here at Ethiopian Public Health Institute. There is the laboratory capacity building, both at national and sub-national level. That there is public health emergency management with all its pillars, the preparedness. In the preparedness, we often do the vulnerability and risk assessment and most vulnerable groups of society and geographic locations in the country. The mandate, based on that information, we also prepare the emergency response plan and often do the surveillance and many of these public health emergency activities in the country. That there is national data management and analytics. They have a center that is actually the new mandate for the institute by coordinating the national, particularly the public health data management and analytics by doing descriptive, predictive, as well as prescriptive analytics for to inform the public health policies in the country. The institute is also the national coordinator for One Health, and the International Health Regulation Coordination Office is also found here at Ethiopian Public Health Institute. So we often monitor, do, and coordinate the International Health Regulation core capacity assessment in collaboration with the WHO, CDC, Africa CDC, and many other partners, both at the national as well as international levels. This is a legal mandate of the institute, and this is the proclamation and the strategic plan of the institute. These are the pillars that we focus on and generate evidence for the Ministry of Health and for the institute, as well as for subnational health bureaus and public health institutes by doing surveys, surveillances, and various infectious diseases and health systems research. By producing policy briefs and technical reports and publications, we disseminate information, and the ministry often uses this information for health policy intervention planning the country. In the public health emergency management, we do both event-based and indicator-based surveillances for 36 diseases and health events. We periodically generate evidence, do analytics, and disseminate information for effective public health emergency management and support the programmatic response of the ministry. We have been also coordinating the emergency operation centers at the national as well as sub-national level, and data also generated and collected from regions at the national level, and we do analytics to inform policy and the programs. The lab capacity building also one of the areas we will be focusing on, and we collect information, build the capacity of regional as well as national laboratories in areas of reference and referral laboratory services, genomics and bioinformatics, particularly for genome pathogen surveillance. That there is biobank and biosecurity data. We have this data and information at national level and do analytics upon the request, as well as sometimes in case of emergencies, we often do the analytics and use the information. One of the flagship program of the Ethiopian Public Health Institute is the National Data Management and Analytics. We have different strategies: capacity building, data strategy, collaboration, evidence use strategy, and sustainability strategies in collaboration with the Ministry of Health and the other international partners. So we are good at generating quality data for informed policy making and decision making in the country. These are some of the experiences in terms of data repository and governance, data analytics, and data translation to evidence, and informing high-level decisions at different levels, both national and sub-nationally. These are collaboration between not only in the country level, but internationally. These are some of the documents and the strategic the plans as well as the policy guidelines we have developed in collaboration with the ministry. These documents are being used by not only the health sector, but other stakeholders also use these documents and national policies of data sharing and evidence generation. These are also some of the success stories. We communicated evidence in diverse platforms, in national and regional health atlases, evidence briefs, and these have been used. We have been using this for the public health, dividing public health interventions and strategies nationally and sub-nationally. The Ministry of Health also used most of the data, the evidence generated by the Ethiopian Public Health Institutes for devising and planning health sector midterm development plan, health sector transformation plan, essential health services packages, and development of the national insurance package, as well as health in all policy, that is intersectoral collaboration activities and strategies used most of the evidence and data generated from the Ethiopian Public Health Institute. We also successfully contributed to the banning measures on non-communicable disease risk factors, particularly alcohol advertisement and public place tobacco smoking, where we often do surveys and surveillance in those areas as well, and provide the technical and the policy briefs to the Ministry of Health to be used by the wider sector stakeholders, both nationally and sub-nationally. This is a conceptual framework adapted from our strategic plan, how we initiate and prioritize evidence generation and translation for effective decision-making. This one is also all about the public health governance system in Ethiopian Public Health Institute. We have all the public health emergency management, the public health research, data management, and the laboratory pillars here at Ethiopian Public Health Institute to effectively support the essential public health functions and the programmatic response of the Ministry of Health. And these essential components of successful country experiences, strengthening data quality, building analytic capacity, generating evidence, translating evidence for decision making and informing decision making. These are the components we often integrate within the departments here at Ethiopian Public Health Institute and the Ministry of Health's programmatic desks and divisions. Thank you very much.
Thank you very much, Dr. Masai, that just gave us an overview actually of the National Public Health Institute in Ethiopia, including some frameworks that guides them to inform decision making. So our last speaker for the session is here with us. Dr. Vernon Lee is the Chief Executive Officer from the Communicable Diseases Agency in Singapore. So now we're moving to Asia. So Dr. Vernon, please take your stage.
Thank you so much for IANPHI and also colleagues in Mozambique for the very warm welcome invitation to this meeting. So in case anyone hasn't already known, we are one of the most recent addition to the National Public Health Agency family. We were just formed last week. So if anyone is newer than that, I'll be... So I just have a couple of slides, and I wanted to show Singapore's experience in using methodologies and metrics for making public health policies and also response. So essentially, the Communicable Diseases Agency in Singapore is an amalgamation of sort of work and functions that exist in 3 separate institutions previously. And so we've brought it all together under one roof. So we do everything from making policies to research, operations, and also supervising clinical management of patients, infectious diseases patients in Singapore. So our mission is to keep Singapore safe from infectious diseases. And we do this by preparing and basically performing surveillance and looking at what diseases we need to prepare for. We also try to prevent the onset of disease as far as possible. But if we have any diseases in Singapore, we of course will protect our population through swift response and outbreak management. And we do this through global engagements. This is why we're here. Research to influence both policy and operations in translating that research and evidence base into policy. And of course, outbreak and management control, and also coordinating across the whole of government. So on the right, you can see that I just want to touch a little bit on our surveillance system, which is where a lot of our sort of metrics actually derive from. So we have, of course, the traditional indicator-based surveillance from mandatory notifications under law, sentinel and syndromic surveillance. We have event-based surveillance as well, where people can actually report outbreaks, and we also perform epidemiological investigations on these events. We also run periodic seroepidemiological surveys, laboratory-based surveillance, especially genetic sequencing of viruses and bacteria. Then we also look at new technologies, one of which is wastewater surveillance, and also perform external horizon scanning and risk assessments. And once we are able to detect any disease, we rely a lot on our national capacities for dealing with these diseases, especially emerging infectious diseases. We also have good clinical guidance development platforms and disease control programs where we can actually react to the threats. It's not working. The next slide. Oh. Okay. Yep. So I thought just have a quick case study on how we actually utilize all of these methods to develop policies in dealing with a disease, dengue fever, which is unfortunately endemic in Singapore, like many other countries in the tropics. So Singapore has a relatively low burden of dengue compared to many other countries, but we still do have quite a few dengue cases, and it is, in terms of case counts, the most prevalent infectious disease in Singapore. So a traditional way of dealing with dengue, basically traditional vector control methods have been effective up to a certain level. Unfortunately, mosquitoes are becoming more efficient at transmitting disease, even though we have very low mosquito indices. The other thing that we're hoping to rely on, which is a vaccine. Unfortunately, the existing vaccines not particularly effective in a very low infection rate sort of a population like Singapore. So we use the same integrated surveillance methods for dengue to determine a few things. Through our mandatory disease notifications, we can look at the problem from year to year. We can see some seasonal patterns. Epidemiological investigations to identify clusters and areas at risk. Even in a small island like Singapore, we do have certain dengue risk areas, and they differ from year to year and from season to season. So when we identify clusters, we can then intervene. And I'll tell you what we do a little bit later. We of course do serotyping and genotyping of the dengue viruses to see potential predictions of future trends, especially if we see a serotype change that the population might be not so immune to. We also monitor mosquito populations, insecticide resistance, and also weather patterns that might affect mosquito breeding and therefore dengue cases. So some of the things that we have been engaging, one is to reduce the mortality rate. I mean, we have cases, but we work with our clinicians and have come out with many clinical guidelines, including trying to reduce hospitalizations to only those individuals that have severe dengue. So we identify severe dengue cases as early as possible, move these people to hospital, and have optimal clinical management to the small number of cases. The vast majority of dengue patients are actually non-severe and can be actually managed in home. So we have reduced mortality rates to less than 0.1%, and most of these are the elderly with comorbidities. The other thing, we do a lot of community engagement so that the community is with us in terms of our dengue control, vector control measures, and also this new project which we launched about 8 years ago, Project Wolbachia, essentially release Wolbachia-infected mosquitoes, but we only release the male mosquitoes. And what happens is that when the male Wolbachia mosquitoes breed with the wild-type female, they are not able to produce any offspring. So that will result in a drop in the mosquito population. So we did some trials, and we showed that you can actually reduce the mosquito population through measurements for the surveillance of mosquito population by about 80 to 90%. But reducing the mosquito population by 80 to 90% by itself does not mean anything if it does not reduce the overall dengue incidence. So at the same time, we have to look at how does it actually reduce dengue incidence rates. So we did a population-wide study where we did a randomized control trial of different sites. And because we know where are the risk areas for dengue, we managed to identify the risk areas year on year. And so this was across 3 or 4 years. And we divided the different regions into those that would receive the Wolbachia mosquito releases and those that did not. And from that, we actually managed to compare that the Wolbachia release sites resulted in about 75% reduction in actual human dengue cases. So 75% reduction is substantial and in the same sort of magnitude as the reduction in mosquito population. And through this, we have now normalized the Wolbachia releases across the island to combat dengue, and we've managed to reduce dengue incidence quite substantially. So we're still waiting on a vaccine, and hopefully with Wolbachia, traditional vector control methods, and a good vaccine, we might be able to actually eliminate dengue as a threat in Singapore in the future. So that's just one case study in the Singapore context, and I thank you very much.
Professor Lee, thank you for sharing the experience of Singapore with the integrated surveillance system and the specific case study on dengue prevention and control. So we have some time now to talk with the audience. So if you have questions or specific interventions, please do share with us. So I will start with one question that we have online. This question is for Dr. Sohail. I will read it now. So resilience in low middle income countries can also mean technical and financial support, that because it is regular and efficient with its own resources, at times regular and obviously much greater in emergency situations. What is recommended if it can be given, and how IANPHI can have a key role in resource advocacy? That's for you, Dr. Sohail.
Thanks a lot. There are a couple of options. One, I think you may recall in the morning as well as in my slide about this Lusaka agenda, one plan, one budget, one monitoring. I think that should be the reference in terms of efficiency and cost savings. Because if you look at Africa context, I think the planning and budgeting are very, very fragmented. You have health sector strategic development plan, and you also have probably majority of the countries also have national action plan for health security. So NAPS, we call it NAPS. So they expect that that is externally funded, while health sector strategic development plan, they expect to be funded domestically. So one aspects of synergy and efficiency is to align both plan. Secondly, the capacity for preparedness and response, I think should need to be accounted as a baseline capacity requirement for routine health systems functions, but we do not do that. Similarly, there are also other vertical disease plans with their own budget, own investment. So we cannot address all of those verticalization, but what we need to do is to come to a case that how vertical investment can also benefit core health systems capacity development. For example, in health workforce, in information system, in supply chain. Otherwise, the same country can remain dependent on vertical programs. We cannot expect a country to achieve self-reliance. And then if you look at those countries in sub-Saharan Africa, under humanitarian context, again, there is a billions of funding only focusing on humanitarian assistance. But there is a lack of bridging between response to recovery and longer term strengthening of the system. And then one other aspect I just wanted to highlight here is that I think even at country level, I think the perception is that public health is an accountability of the National Public Health Institute. Ministry of Health is responsible for healthcare service delivery. So there is some artificial demarcation, but I think in moving forward, public health community, public health institutions needed to demonstrate that public health function and services should also need to be mainstream part of the healthcare service delivery. It shouldn't be only focusing on emergency related capacity located within National Public Health Institute. Second, I think we have Abuja Declaration, 15% GDP to be spent on health in Africa. But the issue, as we know, that economy is contracting. If the economy contract, even the country maintain their allocation to health sector, but the size of the envelope is going to shrink. So we need to find a way to better communicate with Ministry of Finance, Ministry of Planning, so that there can be proportionate increase to the health sector. And I think the argument is that we shouldn't wait for another COVID pandemic where government borrowed money, government printed additional money, I think, to invest in the health sector. But this is why I said in my presentation that we are very good as a health community to account the public health cost during a crisis. But we are not very good at is the lack of inactions on public health during peacetime. So for example, people who are elderly, who has a comorbidity, their treatment cost should need to be accounted during a routine context. And the dividend of investment in public health to showcase that some of this baseline investment can have a more longer term dividend, not just during routine context, but also in crisis. A healthier population goes into crisis, will come out healthy. A sick population go into a crisis, unfortunately, we'll die fast. Thank you.
Thank you, Dr. Suhail. Do we have questions from the audience, please? Please, you can start with your name and where are you coming from and your question.
My name is Shiva. I'm a public health specialist from Zimbabwe. Elegant presentation from Singapore. Dengue came out of Asia. It's now a global pandemic. And I think WHO is struggling to do something about it. I don't know whether they call it a pandemic or emergency. I'm sure Dr. Chikwe can clarify. But elegant presentation, because dengue is out of control globally, pandemic. Same as cholera, which came out of Asia and is out of control. And not enough is being done about it. And cholera is old as public health and sanitary health. But my question is to Dr. Sorry, I'm trying to, Tatania. I noticed that one of the departments of the National Public Health Institutes is environmental health and occupational health. That's one of the big building blocks of public health. Could you say a few words more of what are the indicators you monitor in environmental health as well as occupational health? Because this is a very neglected area. And then maybe have you considered instituting weather stations at our health facilities so that you get weekly reports of the changes in climatic factors, which might affect the changes of diseases like malaria, dengue, cholera, measles, etc. Thank you.
No, thank you for the question. So actually, it's not a department. It's one of our strategic areas in the National Public Health Institute in Mozambique. We have this area since 2016, and our main focus was on climate and health. We do not measure a lot of environmental health indicators apart from the ones that are related to climate so far. But we are moving there to have more environmental indicators being measured. For example, the indicators related to air pollution. So now we have an agreement with the Met Office in Mozambique, and they are having these mobile stations to measure the quality of the air. And one of them is in Marraquene, where we have our institution, and we are discussing in moving this station to our building in our institution, so that we will have the indicators being measured within our institution, and we will have also the capacity to interpret the data and analyze it. So we are moving to have more environmental indicators to be measured, but we are not getting there so far. The same as for the occupational health. So in the past years, we have this focus on climate and not including a lot of indicators related to occupational health. But of course, now we are concerned with indicators related to occupational health that are related to climate. So slowly we are moving, taking the opportunity that we are working with a lot of climate indicators in our program and trying to incorporate the other indicators related to pollution, to even non-communicable diseases, to other diseases that we have been neglecting in the past years, apart from the infectious diseases. So we are moving slowly, but I think we will getting there. So the other question is what weather stations, right? This is something, it's a conversation that we have to have with the Met Office, but since we have an agreement since 2016 with the Met Office in Mozambique, I think one day we will get there using our institutions. And since we are growing so fast to the province level, even having institutions located in our provincial, it could be something very interesting to have. So now we are working with the mobile stations to measure the air pollution, and they are thinking of expanding to the province level. Probably we will have in our provincial delegations also stations are actually not measuring only air pollution, so the quality of air, but I think they have also some variables related to the climate in mobile stations. So that could be very helpful even for us as a National Public Health Institute. And thank you for the questions.
Thank you, Dr. Tatiana. We have one more question online. This is for Dr. Professor Lee. The question is from Scott Dowell from the WHO Global Health Emergency Corps Secretariat. Scott, good to hear from you. So the question is the Wolbachia now distributed across the entirety of Singapore, and is this sustained? That's the question. But maybe before you answer that, we have one more question. Is if it's for the Professor Vernon, you can ask. If not, you can go ahead, even though.
It's for everyone really. It's we heard from Chikwe about collaborative surveillance, and in Jean Casse's presentation, he mentioned the importance of collaboration around data integration. But I'm interested in the process of defining metrics. And Henk, in Henk's presentation, he mentioned stakeholder participation. So my point is, if you want to have collaboration around indicators and surveillance, then to what extent do you need to involve multiple stakeholders in defining the metrics? Because people need to understand collectively the importance of the metrics in order to be participating in their collection and sharing. So I'm interested in views on how we get that collective ownership of the metrics that are then used in collaborative surveillance.
Thank you. So Professor Lee, please go ahead. And next, Dr. Hank online will intervene.
Yeah, I'll talk a little bit about dengue, and then I also have just a short reply to the thing about participatory or collaboratory surveillance. So I was just conversing with a colleague from WHO, and regarding the question about is this a acute sort of pandemic emergency? I think the definition of pandemic is that it needs to be sort of cross-border acute transmission of a disease. So while dengue does not quite meet this criteria, it certainly is an issue that we have to deal with collectively and globally. I fully agree that it needs to be, sort of novel methods at which we tackle this particular disease. I mean, Wolbachia is one of them. I mean, in Singapore context, it does cost quite a bit of money and other resources. So I think there needs to be solutions that each country will have to tailor-make to their own sort of local context. And I don't think there's a one-size-fits-all solution. Investments in things like, new vaccines will have to take place as well, and so on. To answer, I think, Scott's question about the use of Wolbachia in Singapore, so we use the suppression method rather than a replacement method. And the suppression method, like I mentioned, does require the release of mosquitoes, male mosquitoes on a week or sometimes even, a twice a week basis. So we don't release that across the entire island, across the entire year, because that will not be particularly cost effective. What we do is that we identify areas at risk and we release them to those areas, and the areas at risk would depend on many other factors, like I mentioned before. So through those surveillance, we can determine where the areas at risk are year to year, and it will release the mosquitoes accordingly, so that it can have maximum effectiveness. So to our other friend's question about sort of collaboratory surveillance, so we participate in a lot of these surveillance activities as well. And I fully agree that you first need to agree on the common metric to measure, because if you can't agree on a common metric or you're measuring different things, then you can't compare them across different either regions, countries, and so on. So there needs to be a collective understanding of what matrices to use. And you have to convince yourself what are the matrices going to be used for, or what can they be translated into. So whatever matrices that you measure for surveillance must be translated either into some policy, some operations, or some action. So I think before you start on actually measuring those things, you need all stakeholders to come together to actually agree on what you want to measure and why you want to measure it and how you want to use those measures before you actually start embarking on a very time-consuming or expensive exercise in trying to measure those things. Thanks.
Thank you. Shall I take over? Thank you very much for the question. And I think it's rather crucial to involve all kind of stakeholders in developing metrics, because we are very capable of developing all kind of metrics, and we need a better understanding to have them also be better used. I am rather active in the burden of disease metrics, and I know how difficult they are to understand what it's all about. So involving stakeholders in understanding and the use of metrics, I think it's crucial. However, what was also mentioned by the previous speaker, it is more important that you have the reason why you have certain metrics in place. So what are the issues that you really want to measure and you want to develop a metric for? And that's where actually also the stakeholders come in. It's not only to bring in different perspectives, but also they have very often different ideas, different insights in what kind of issue of what kind of interventions work at the ground and which don't. Thank you.
Thank you, Dr. Hank. We still have a few minutes. Is there any other question in the room? Please go ahead.
Yes. Sorry. My name is Charles Akech. I work from Annabelle as International Health Data Advisor. My question goes to Dr. Hank, specifically with regards to the methodology, the foresight expert. How would he foresee this particular kind of expertise being passed down to the young NPHIs that are coming up? Because it has also been mentioned that there are issues with data, particularly with regards to fragmentation, access. So how will you advise these young and upcoming NPHIs with regards to developing and learning this particular kind of new or specific kind of expertise? Thank you.
Thank you for the question. We are very active as well to do some capacity building on foresight as well. And yes, it's about data. We have to have a good database on all the trends that we are measuring. It's not only about quantitative aspects, it's also about qualitative aspects. I just mentioned the stakeholders. However, to do such a foresight study, I think it's rather crucial to have a better understanding how the future might look like, and also to support policy making. Policy making is about the future, so you have to have a better understanding how that future looks like. That capacity building, we're doing that within the European context. We just had a joint action program where we were doing capacity building. However, we're also looking into options to see, can we collaborate with WHO headquarters to offer foresight services as a part of evidence-informed policymaking. I hope that will go on, and in such a way, I think it will also reach out a much larger audience. Thank you.
Thank you, Dr. Hank. Next question.
Yeah, I had a question regarding Dr. Tatiana's presentation that I was very much impressed about. And do you? Now it's okay. So I was very much impressed by your presentation, Dr. Tatiana, on health vulnerability indicator related to climate change, and some of your map showed that you had quite heterogeneous exposure to those indicators in 160 districts, which is very much impressive. So my question, although you said that there were limitations in the data, how do you use those heterogeneous result indicators to to prioritize maybe area of action where the indicators are worse than others, or do you plan to that in the future? Thank you.
Thank you. I didn't get your name, but thank you for the question. Yes, this is how is Mozambique. It's very heterogenic, even in terms of exposure to the extreme weather events and the climate variability. Actually, for the assessments, we have divided the country in agroecologic areas. So to try to address these differences that we have between the regions and across the country. But what actually this assessment inform is how vulnerable we are to the climate change in terms of the health sector. And we are using this information now to provide the evidence to inform the Health National Adaptation Plan. Since we will be working in the National Adaptation Plan and taking into account these findings, we will definitely prioritize the actions in terms of adaptation, so across the country. So this is what we are doing now. And since this assessment was for 2019, we are updating some of the indicators in terms of the timeline that we used, because we used until 2019. And there will be some differences in terms of exposure, since we were hit by a lot of cyclones in the past 5 years, so or 6 years, and even with a lot of floods and with the El Nino, the droughts. So I think in terms of exposure, something have changed. Even in terms of adaptive capacity of our system. So this will provide us with the proper information to prioritize in terms of measures and strategies of adaptation that we wanted to include in the HNAP for our country. Thank you for the question.
Thank you, everyone. Unfortunately, we are coming to an end, but we will definitely have more time to discuss. This was a session to discuss metrics and methodologies to support equitable public health policies. We had presentations from different parts of the world, from all the continents, almost all of them, and also from a global perspective. So I would like to thank the speakers, all the panelists to participate, and all of you for your contributions and questions. There were a lot of keynotes that were related to fragmentation or integration, the need to define metrics, so coming to a common understanding on indicators in order to inform decision making. They were mentioned about the need to have approaches not only related to crisis, but also to the routine context. We discussed the need to have data on not only quantitative, but also qualitative data, including participatory approaches and multi-sectorial approaches. So with that, I would like to end with a very known African proverb that I think summarizes not only this session, but what we are doing here in this meeting. That is, if you want to go fast, go alone. If you want to go far, go together. So let's go together and move forward with this meeting and also with future collaborations. And we'll have a break now. Thank you, everyone, for your participation.